So welcome everybody. Welcome to this latest event in the NHS Providers Programme on how Trustwide approaches to improvement, led by the board, can help us in this phase of the pandemic, in recovery and beyond. The focus of our programme is on board level peer learning, and we're really aiming to eke out those actionable insights from trusts at different stages of their improvement journey to share across the board with you all. So we're delighted to be partnering with the Health Foundation in this endeavour, which enables us to draw on their extensive work on this topic over many years and the learning from their community of improvement leads in the sector. And you're all on a journey of discovery with us today, because this is our first deep dive peer learning session, where we're hoping to provide a safe space in which you as the audience can question and interact with your peers from a particular trust, who are very willing to share how they've moved towards their ambitions in terms of embedding trust-wide improvement and what they've learned along the way. So we're incredibly grateful to colleagues here today from Central London Community Healthcare. So warm welcome to our panel, who will introduce themselves shortly. So warm welcome to Dr. Jo Medhurst, Medical Director and Deputy Chief Exec, to Professor Charlie Sheldon, Chief Nurse, Elizabeth Hale, Director of Improvement, and Dr. Carol Cole, Non-Exec Director, the Trust. We're going to be hearing from them very shortly, and they'll say a little bit more about themselves and their connection to the improvement work as we kick off. But just before we start off, hopefully most of you know me, but I'm Miriam Deakin, Director of Policy and Strategy, and I'm really looking forward to chairing today's conversation today. A little bit of the obligatory Zoom housekeeping before we get into the meat of the conversation. So we're aiming to make the session as interactive as we possibly can within the confines of Zoom. So please do have your camera on if you're happy to do that. Do indicate if you'd like to ask a question and come in verbally. If you just use the raise hand function or simply wave at me, I'll look to bring you in during the course of the conversation. We'd also really encourage you to use the chat function. If you want to put any kind of questions in there, I'll make sure that we get to those and that those are posed to our panel as well. And just to make you aware, we are recording the session. That's so that we can play it back to you and also share it with a wider audience. But it's important that we let you know that we're doing that. If you do lose contact with us, just re-click on the link and I'm sure you'll be able to rejoin. And we'll also be gathering up all the information that colleagues share today and playing it out in some board bites. So writing it up for you. So don't feel too much of a need to make too many notes. We're just really happy that you can engage with us as we go. So really looking forward to this. It's a new format for us and a sort of facilitated deeper dive conversation. So I've got some questions to pose to the panel, but as I say, we'll be pausing to take your questions and do just put them in the chat or raise your hand if there's something that you want to ask at any point during the conversation. So without further ado, I think I'm going to hand initially to Elizabeth, and you're going to introduce your fellow panel members in a little bit more depth, I think.
Yes, thank you, Miriam. So I'm Elizabeth Hale, Director of Improvement for the Trust, and we will just introduce ourselves in turn and just say a little bit about our kind of connection with this agenda. For me, I'm really the new girl on the block at the Trust. I've been here for 5 years and more recently have taken responsibility for QI, and I'm very, very committed to making sure that this is a real success in the Trust. But for all the other members of our board here, they've had a much longer and stronger connection with it than I have. So I'm very happy to welcome them. Jo.
Hi everyone, I'm Jo Medhurst. I'm the Medical Director of the Trust and the Deputy Chief Executive. And I'm the old girl on the block. I'm the longest standing executive. And my connection with QI goes all the way back to, some of you may remember, the Primary Care Collaborative, probably about 15 to 20 years ago now, which was led by Don Merritt. So I learned QI as a general practitioner, which is my professional background, and it sort of just sparked a lifelong interest in it. And I suppose what I've got a lifelong interest in is change. I was also then very lucky to go through the GenQ programme supported by the Health Foundation. Thank you very much for that, which gave me a master's degree in the leadership of QI, and then consolidated a lot of my theoretical understanding of QI that I can then apply into an operational sense. So that's my background, and I used to lead QI until Elizabeth came and took my job from me. So that's me.
Thank you, Jo. So Charlie, if I can introduce Charlie next.
Hi everyone, I'm Charlie. I'm the Trust Chief Nurse. I've been with CLCH about 9.5 years now, I think. And my connection is, I think we in quality use shared governance and embedded that in 2020 as part of our quality strategy in order to make improvements around our 4 campaigns around safety, patient experience, education and smart effective care. But we started dabbling with shared governance probably about 2018. And it is recently when we formalised it, we've connected it more strongly to the continuous improvement work at the Trust as well.
Good, thank you, Charlie. And then finally, if I can hand over to Carol.
Thanks, Elizabeth. Hello, everyone. I'm Carol Cole, Non-Executive Director on the board of the Trust and Chair of the Quality Committee. I arrived at the Trust, not quite as old as Joanne, in 2014, I think. Already a huge fan of quality improvement and everything associated with it. I'd already been involved in that at my previous trust, which was Hounslow and Richmond Community NHS Trust. And before that, although I trained as a clinical psychologist, we're having a mindset of what can we do with clients to help them improve the way that they function. It was already embedded, but I also spent 3 years with Shell as an organisational consultant, and Shell was very sophisticated in how it was using quality and quality improvement. So I sort of brought those blends of insight when I arrived at CLCH and was delighted to find a very receptive colleague in Joanne at that point. So that was my journey to here and our journey since then. Thanks.
Fantastic, and welcome to all of you. So quite an expert panel with a range of experiences then, colleagues for us to draw from. So just to kick us off then, a question for each of you, and I'll perhaps go to Elizabeth first, if that's okay. Can you tell us a little bit about how you each view your own role in supporting your ambitions for a trust-wide approach to improvement?
Yeah, so I think for me, I've got this on 2 levels, really. So one is I have the direct responsibility for the QI team, and the board has invested significantly in that team over the last couple of years. So really wanting to make the most of QI right across the Trust and realising that the team that we had before was too small really to do that. We're very geographically dispersed. And so I think having a significant kind of sense of a presence for the team was something that we wanted to build. But I think I see my role as more of the sort of conductor of the orchestra and trying to ensure that we can link lots of other initiatives to think about that through the lens of quality improvement. So when we're doing our business planning, for example, or we're developing our information resources, all of those things, I'm thinking about how do we deliver that change so that it will support quality improvement. So I'm kind of like the eyes and ears of making sure that culturally and practically that we're investing where we need to make sure that we get the best out of QI.
Thanks, Elizabeth. And interesting from what Jo said already, it sounds like you perhaps created that dedicated role, which we might want to come back to at some point as well. But Jo, can I come to you next? Same question.
Yeah, so I think it will be interesting to look at our maturity over time and how our roles have shifted depending on where the organisation is its understanding of what QI is and what it has to offer, and as it's changed its approach to change, really. I think I have 2 roles as a medical director. I think I am often the theorist in the group. I horizon scan theory. I will look at academic stuff, publish stuff. I'm part of the Q community. There's that wider network of community of practice of sort of QI experts, zealots and change agents. And a lot of that is sharing of information. I tend to take a view of that, look at it and think, does it apply to my trust? Can we use it? And then I will lobby and advocate for those elements that I think shift the trust into a slightly different, maybe a slightly more mature place. So I think I'm a bit of an advocate for some of the application of theory. The one particularly around COVID's been making sure that we see ourselves as a complex adaptive system, not in our sort of strategic management theory. And actually managing COVID, I think in particular, I've been very struck by it's been such a complex activity. Using sort of the Dave Snowden work and the Carnarvon models actually has been something I've brought into the trust to help look at how we might adapt and how we might change. The other thing as a medical director, I think I can sometimes just be a bit challenging. I can use my positional power in a way that sometimes I think non-executive directors and even some executive directors aren't quite as empowered to do. Doctors get a lot of people, I mean, you may not agree, but in my trust, doctors get quite a lot of bandwidth to be a bit challenging. And I remember a particularly pivotal moment when we were doing a business case to get resource, and I challenged the board that they were just giving rhetorical support to QI, not real support. And there was a horrible pause and everyone looked a bit disgruntled, but actually it shifted us. It was a really significant move to getting the money to get the team to do the work. And I remember that particularly. And that was something that I think as a medical director, I can do, where sometimes other people may feel more reluctant to do that. So I think so theory and advocacy, and then the power bit of being a medical director, positional power.
Thanks. So that is really fascinating, and we might want to come back to that, colleagues, as well, to think about how you build that cross-board support for some of these endeavours. It's really interesting. So Charlie, perhaps come to you next for your perspective.
Thanks. So I suppose, as I've already mentioned, a really important bit is for me has been as an executive to ensure that our shared governance processes sort of widen away just from quality and sort of fit in with the wider QI agenda. But in order to make it a success, and of course shared governance is around the most junior staff in the organisation problem solving, it's needed quite a lot of lobbying. So quite a lot of my work has been challenging colleagues and the clinical divisions around not going straight to the solution, but allowing staff in bands 2 to 6 to set up councils, make decisions. And I think part of that that's been really important is when people do make decisions and make change for the better, is ensuring that I can help them with lobbying for the resource they need appropriately to do that, but also making sure we share that learning across the organisation. We don't do it in silos. And a big part of that part of QI that's been important for me really is that staff feel that they're appreciated and listened to when they make those solve those problems. So we spend quite a lot of time publicising the work staff do, and actually at our trust business meetings we've had very junior staff come and present to rooms of 100, 150 people around the work they're doing, which has just been phenomenal. Of course that's become slightly less daunting in a way for them, because Teams is a slightly less daunting feeling than talking in a huge room. So I think they're really important parts. The other bit that we've done is we've started to move the shared governance work into areas other than quality. So we badge it under our quality campaigns, but we now badge it under the 4 campaigns of our inequality and equality strategy as well. So we want to make it a tool that people at more junior positions at the trust can use all the time. So I think that has been my part, and the team that I lead, that has been really key to their work.
Thanks, Charlie. And Carol.
Thanks, Miriam. I was thinking about this question and how my role as a non-exec has hopefully helped rather than hindered. And I think it has many aspects. The first has been to sell it to non-exec colleagues who may have been unfamiliar with the concept when they arrived. I think it's fair to say they are familiar with it now. And to support exec colleagues, so to support Joanne, Charlie and Elizabeth, so that it's a whole team approach, not a them and us between execs and non-execs. And just as an aside, I think a factor which has been hugely helpful for us is that we are a really well-functioning board. In my day job, I've worked a lot consulting to boards which are dysfunctional. So I know what good can look like, and I think we're a good board. And I think that really helps, because it means that people are receptive, whether exec or non-exec, in listening to what colleagues have got to say. I've endeavoured to be tenacious and relentless and possibly boring about it, because I think once you get quality improvement and all its aspects, it's really difficult to unknow it and to unknow the value that it can bring. So you do want people to understand and appreciate the benefits of doing it. Specifics, I recall, are trying to persuade our previous CEO and chair to run some sessions for the board on it. I didn't quite make the sale. I kind of made one sale, and we did have one session on it. But our current CEO and chair are very supportive, and that's been hugely helpful in making sure we all understand the concepts, the methodology, the theory that Joanne has spoken about, and are really working collectively. We get the synergy of the board supporting it wherever it can. And the analogy that springs to mind, I don't know if it's helpful, is that in curling, which is the Scottish Olympic sport you may be familiar with, the disc slides along the ice. But in fact, the people who are really helping are the people in front who are brushing and sweeping the ice so that the disc can run smoothly. And I think part of our role, those of us who are here on this call, has been to do the brushing and the sweeping in front of the quality improvement disc as it has slid along. It's not always obvious, but it's catching opportunities to make the sale, to say a bit about it, the water cooler conversations, the making comments at boards about wouldn't it be helpful if we did this. So it's really snagging every opportunity that passes by and kind of getting a tipping point of support for it.
Well, thank you all. I'm already struck by how close-knit a team you are, although you've each described a slightly different role that you bring to the table. That's really compelling. Shall we start then with kind of your experiences, your journey towards building that kind of solid board support for trust-wide improvement and a quality improvement approach? Do you want to tell us a little bit more about that journey and how you've kind of built that support across the board? Were there any particular events that triggered it, or any particular interventions from yourselves? Who wants to kick us off with a little bit more about that journey towards getting that kind of collective shared purpose?
I'll start with that, Miriam. I think I love Carol's metaphor, and I think there is something about that. And if you put theoretical, what we're talking about is gesture response. So we've all taken accountability to do gestures and see what the response might be, and just the tenacity. So Carol and I were talking about whether we talk about SPC just before people came on. And we've been having that conversation about the value of SPC for probably 8 years, haven't we, Carol? And the initial way that we did that was start to show people. So I use I run the medicines management team. So I asked them to put all of the incidents, the medicines, into SPC charts. And Quality and Carol, because she said, yep, I'd let you do that at Quality Committee. Let's start there, Joe. So we started there, and then we got very positive feedback about SPC charts. And then we put SPC charts in other areas of the work. And then we've got NHS elect to come and do some sessions on it. And so we built and we built, but we are together as a group, I would say, sensing when we're getting amplification of those ideas, when we think actually, yep, it's going quicker, we can keep brushing. And sometimes we've had to stop. And because I've been doing this a very long time, we have gone down quite a few cul-de-sacs. And one of the things I'm always very mindful of is when I come to presentations and people tell the QI journey like it's just this massive success that you can do in a very short period of time. We have made all sorts of false term. We had, when I was leading QI, we did a whole series of training programs and we got people trained. But because the organisation wasn't warm enough, then what happened is they'd go back into their operating divisions and they weren't supported. And really, they left. They would leave with those skills and go and get jobs in places where they could go and practice their QI skills. And actually, we had to have a really critical look about how we do that, what we do. So there wasn't any one big dramatic thing that we've all done. It's just this endless, as I think Carol really, really exemplified it, just keep on going, be tenacious and accept that some of the things you try won't work and go, okay, then I'm now going to try something else. But pay attention to what you've learned by the cul-de-sac journey, as well as what you get by when you're actually on that success trajectory. So yeah, persistence and tenacity, really, and keep being open and have enough enthusiasm. If you believe this is the way that change happens in organisations, that actually drives, we've got the joy at work, keep at it and meet colleagues maybe around the wider system that can keep that belief. If you're feeling a bit dispirited, meet somebody else who's actually on a slight upward trajectory. So I haven't got a specific thing, but I think it's that gesture response and just endless gesture response analysis, conversations and movement forward. Does anyone else want to add anything?
Joe, I could come in. I think you're right about the tenacity. I think with the particular part where we let staff set up councils to do improvements, I think early on there was quite a lot of disquiet in a way about how that might work. And so I just decided to do it with the team. We said, do you know what, we're going to put it in the quality strategy, and we know not everybody doesn't agree with it, but we'll prove you wrong. And I think our staff did. And I suppose in some ways we had to be a bit challenging back. So I remember really early on, one of our teams of, I think, really junior stuff, they were band 3s and nursery nurses, did a piece of work where they looked at unhappiness in a team, in a really pressured team in children's services, and they did their own surveys, they did all sorts of things. And some of the sort of more senior members of the team said, oh, but you know, it seems to be really obvious things that they're doing. And of course my response was, well, if they were obvious, why didn't you do them as leaders? So we had to do a bit of challenge back, and actually quite quickly I think people understood that sometimes these very simple things in improvement that are missed, but it was really about just being a little, getting us to be a bit challenging back, actually, about how we did it. And let's be honest, I wasn't an immediate champion for SPCs, was I, Joe? But you know, we got there. So we all have areas that we need to be challenged on, I think it's fair to say.
Thank you. And I'm going to ask in a minute, actually, how you kind of set the tone for the organisation as a whole, and how you kind of get that that focus to filter down from the board. But just before we get into that, I wondered if it might be helpful for colleagues if you just talk through some of the benefits that you have seen from adopting a QI approach and from the investment of time that you've put in. Because we sent some information around to colleagues in the audience ahead of the event with a bit of a summary of information about the trust, but might be quite helpful for us just to get out on the table. What are some of the biggest kind of benefits and steps forward that you have seen from putting the time into this approach? Elizabeth, don't know if you want to kick off, and then I can perhaps come to Carol.
I mean, a very live one and current one is Charlie and I have literally just come from an event celebrating our first collaborative. And this is a Joy and Work collaborative. So it's been the quality improvement team and the shared governance team coming together to support over 100 staff across the trust. And again, very dispersed teams working on different things, but having a look at what's important to them, what are the blockers, what are the things that they need to address. And they've been doing that. So those teams have been trained, supported, they've had a facilitator working with them, then we've had a poster competition. Now that's a lovely thing to do, and Joy and Work is absolutely great. But I think the really critical thing for me is that Joy and Work initiative supports one of our 2 key priorities for this year, which is about staff health and well-being. So we were really clear this year that we wanted to focus on health and well-being of staff and restoring services. So it means that QI isn't the sort of soft, fluffy stuff. It's not just a lot of projects that people are interested in that may be of interest to them, but aren't kind of critical to the core priorities of the trust. This is absolutely front and centre our business. And I mean, it's been lovely today to listen to all the different things that they've been doing, but it is very much a kind of a bottom-up groundswell that all of those staff are trained and will have those skills to be able to take on into other areas of work that they may well want to pursue in future as well, using those QI skills.
Fantastic to get that integrated into core business, isn't it? Charlie, colleagues, did you want to come in there, add to that?
I could, Miriam. I mean, one of the things I think is very helpful is because we use the model for improvement. So having a defined change methodology means that actually when we start to look at change we're a very, very big trust. So we cover a population just under the size of Wales. So we've actually, if we're doing different change methodologies, it's very easy in the trust to start to talk about apples and pears. So there's something about the consistency of it, the use of driver diagrams, which helps break down the elements we might want to focus on. So there's something about the underpinning methodology that's helped sort of unite the organisation into a way it approaches change, which is helpful. We have used it recently around COVID when we looked at the discharge to assess models across, we're in 4 ICSs, and we use QI methodology. So what worked in one ICS that didn't work in another? And it allowed us to look at behaviours, change up stakeholder management, all sorts of areas, and we can compare and contrast successful change to unsuccessful change. So that's getting quite sophisticated. And we're now bringing that learning into how we're trying to roll out virtual hospital systems, which we've just invested £500,000 in, to say, right, we've learned on this, we've captured that learning. And actually, with organisational change and shifts, capturing that in writing and remembering what it is important, because otherwise you rely on people's individual memories. And of course, we're a London trust. There's huge movement in our leadership teams, in our clinical teams. So capturing that has been really, really helpful. And it's just made it more disciplined, more sort of, it feels like we've brought a professionalism into the trust in how change happens across, up and down and around, which means we can have slightly more sort of useful conversations that drives effective innovation, change and diffusion. And I think, over the years, we've done many projects, insulin misses on wards, the use of controlled drug maintenance on wards, we could go on and on. But for me, it's that underpinning methodology now allows us to have quite sophisticated conversations about change rather than just topics. And because Charlie's done shared governance and we've done it from the bottom up, it's not just us at senior level happens. We can have the conversation up and down the organisation to all the staff cohorts. And we've still got a way to go because we're still training people, but it's allowing us to have an organisational conversation, not maybe a senior board level conversation. And that's really important too, I think.
I think that trust-wide conversation is key, isn't it? So you've obviously invested quite heavily in senior leadership time and then in training and developing people at all levels in the organisation. And so is there any more you can say to expand on how you go about creating the time for people to do that, or how you encourage people to prioritise it?
As Charlie said, Charlie, I think I'll bring you put it into a strategy, Charlie, don't you?
Yeah, you do. So you get everybody to sign up to it so that they can't dodge it. And I think we need to be flexible. And one of the things with the shared governance component was you just have to be tough around colleagues making the time around the staff for this, and not our staff making the arrangements around exec's diary. So we do all of our, we have lots of, but even just for shared governance, lots of activity, and we make time around the staff group, so we don't put them in when everybody's going to be out on district nursing visits. We just have to sort of champion being flexible, really. But yeah, putting it in the strategy really helps, because once you've agreed that, as I said, people have to commit. So that worked very well indeed.
And I think the other thing I'd bring in is Carol, because the other trick is you have a non-executive who says, well, why has that not happened then? Carol, do you think that's fair in a very nice way?
Well, absolutely. Charm offensives have paid off, I think, with the rest of the board. And if I can just build on what colleagues have said, they will know I'm a great believer in working smart and not working hard. And I think it was hard work at the beginning because we were kind of, pushing, an agenda, if you like, that we could see the benefits of, but maybe colleagues couldn't. And so we had to invest in the time and the training, in fact, for the board. We had several training sessions so that we raised the education of everybody in the nicest possible way. And the benefit of that, which is what you asked about, what are the tangible benefits, Miriam, are that, first of all, you're working with colleagues, which maybe sounds rather trite, but actually it's hugely helpful when you know that you're all in the same thing together. And we were, because we'd invested the time and the effort of the board on that. It means that people can speak the same language, which is hugely helpful because it just saves time and effort. And thirdly, if we think about, for instance, SPC, statistical process control, about which I am a huge fan, I can't resist the temptation to just say how fantastic it is. A specific example of the benefits of that is that at the board, we have done our very best, and at quality committee as well, to make sure that our KPIs, wherever possible, have had SPC applied to them. And what that means is we haven't set ourselves KPIs, either as a quality committee or as a board, which the system cannot achieve. So we haven't set ourselves impossible targets, stretch targets perhaps, but ones which we know we have the capability to deliver. And that's been hugely powerful. And we pioneered that at Quality Committee so that we get the raw data, but we're able to convert that into information but more compellingly, we're able to translate it into intelligence, so that what comes to the committee and now increasingly to the board is intelligence. So we have, if you like, the intelligent board looking at what the key messages are, because we've been able to distill the key messages using SPC in particular for some of our data. And I know that the Quality Committee, we've also been really supportive of Charlie and shared governance. And I think people begin to get the message, and suddenly you've got a coalition of support. It just makes life so much easier.
Really helpful, thank you. And a couple of questions are coming through from the audience now as well. So colleagues, do drop your questions into the chat, or raise your hand if you'd like to ask something of our panel. So I think on a similar theme, actually, we've got a couple of questions from Debbie and Diane. Again, just looking for, I don't know if there's any sort of practical, crunchy examples you can share about how you translated this for staff at all levels. So thinking about porters, healthcare assistants, all the different people that support our endeavours. Anything on that will be really helpful. And quite a crunchy one around the staff survey results, and whether you've seen any translation of benefits into those results at all as yet.
Perhaps if I could just start off on that. I think there are a number of things about the kind of bottom-up approach. So I think, for example, our training is done at all different levels. So we kind of start off with bite size. There's lots of very easy access training. There's also things that are called lunch and learn. So it's not just about QI methodologies, but a whole range of tools and techniques that help around change, innovation, using new technology, that people can kind of dip in and out of that. So I think that has been very accessible. And certainly the technology that we've now all got access to really helps with that, because we're incredibly dispersed as an organisation. I think the other element bottom up that has helped us is we have invested significantly in the comms and social media agenda. And that's both true for Charlie and the quality team, and also for the QI team. So we're investing a lot in Twitter, making sure on our intranet things are easy, accessible, little bite-sized videos, lots of links that are easy for people to understand what's happening, and not taking a lot of their time, putting it in different sorts of formats. So I think all of that helps. We have seen, just in terms of the staff survey, what I'm hoping will be the turning of the corner. We had, we track the staff survey results around staff engagement over a number of years. We could see it dipping, and last year's results were certainly an improvement for us, and also a comparative improvement compared to other community trusts. When you have a look at that kind of a crosswise look, how do we look compared to others? And obviously what we're hoping for now is that we will see that trend will continue to improve, but we're waiting for the next lot of results. But yeah, our staff survey data is absolutely critical in all of this, because we're looking at those key elements that are about the culture for improvement in the trust. That's the set of metrics that we're really targeting. We have seen that starting to turn around.
And Elizabeth, I think just to add to that, one of the indicators, the one around communication with senior managers, was better. So it was out of our peer group, had become better, having been somewhere in the middle. And I think this was a contributory factor. I think the other part on this about making it people feel it's genuine is not putting obstacles in the way when they come up with ideas. So I don't think I've ever put us into the red with the things that I've agreed to fund when people come up with improvement projects. I've never given our finance director a panic attack, but actually in a pressured NHS system, we get very much into the habit of, oh, you can't have, we can't have folders to do this, we can't have things. And so one of the things that's really important is we found small bits of money to make sure that when people come up with ideas and they're really good, I don't think any of our teams have ever come up with something that is not something we should do. We give them a little bit of support financially or resource wide to actually implement it. And that was early on one of my reflections before we went into the strategy. I would say, oh, can we, oh yeah, of course we'll just buy those things, and it would take about 4 weeks for me to get a service manager to, click on the budget agreement, because they said, oh, we can't spend £50 on a thing. So I think that has really helped staff actually in coming forward, because they it's very frustrating. We've all been there where you just think such a small thing will help, but we're not allowed to have it. So we have been a little free and easy in terms of, trying to push that forward. And it's really.
If I can build on that, Miriam, the one as Charlie's took on, we had a team who was actually presenting their project. I think it was a London-based event, and they couldn't get funding for an A5 poster. They just couldn't. The CBU was saying, well, they just wouldn't approve it. And I think one of the things that we've had to do as Chief Nurse Medical Director is it gets escalated to us quite quickly. And this is a really small, it's about, £100. And actually we make it, that's not, so it gets senior attention very, very quickly. And if I wanted to put a bit of theory, and I talk about high fits, balcony and dance floor, our staff are allowed to escalate stuff like this up to us very, very quickly. And we will come down to the dance floor and say, get it done, get it sorted, because it's not acceptable not to. Because the message it then gives is the rhetoric message. We don't really mean this. And I think there is something over the years about the not really meaning it. If you actually keep doing that with stuff, even for small little things, actually the gesture that makes is much, much more meaningful than you would think. So senior attention and being the unblockers for these things are really, really important. I think it's a really good point. And we all do that, non-executive execs at the senior team. We will unblock these things and actually go, that's not the culture of the trust. Thanking you very much. And just nudge it forward.
Yeah, that's really interesting. And as well as those sort of routes of escalation, I'm just picking up another question in the chat there. Is a sort of QI approach embedded into the rhythm of sort of daily, weekly reporting as well? As a question from Hannah there around how you work that. You talked about the strategy, so the strategy is definitely there, but is it kind of filtered through the other reporting?
I think there's a polarity here. If I start, because the way we do reporting in the NHS is not based on a complex adaptive system. It's based on a much more operational model, mechanistic model. So you have to do both. So in our performance metrics, stuff that goes up into our strategic oversight meetings, we still have KPI charts. They're RAG rated with a bit of narrative, maybe. We do look where we can. Someone asked about SPC. We are SPCing everything we can. Incidents, vacancy rates, sickness rates. You can even do patient experience, as long as you have a narrative there as well. But you can do all of these things and SPC them. And there's some fantastic resources now on the national NHSE websites, which we are pulling on, aren't we, Elizabeth, to use also to make sure that we are aligning with the national way of doing SPC. So you can do this always, but you do have to hold this very odd polarity that I don't think the reporting and performance reporting system of the NHS is quite caught up with this yet. So you sort of have to have both sorts of reporting and actually live with that slight messiness and polarity, I would say. Elizabeth, would you agree with me on that?
Yeah, no, I think you're absolutely right about the reporting. So, and again, this is about where we are on our journey, isn't it? So what we're just about to invest in is two things that have been kind of embryonically we've been working through during COVID. So very recently we did with NHS improvement, making data count, I think probably for the third time, I think we've worked out. And we are now reviewing all of our performance packs, but in a way that's a kind of a symbol of what we're looking at for a change in our approach to the performance management culture within the trust. So the conversation that we're having about those performance management meetings that we have every month is that we need to shift them from what are the problems into what are the improvement priorities and what are the plans that we've got to put those things in place. And that sits alongside some work that we've been doing around leadership principles. So this is how we as a group of executives have been talking about what we've seen, particularly through COVID, I think, that kind of open conversation about what are the issues, what support do people need, can we have an honest conversation about what's working and what isn't. And I think that will really help us quite significantly in this kind of newer approach to performance management. So I think it's interesting to look back, but I think also it's about landing the sense of there's more work to be done here and we know where we need to target for the year ahead. And it's that kind of performance improvement focus that I think we'll land on. Just one other point though from the chat was there was something about those kind of regular events in our management cycle, and I am acutely aware of that. So we used to have, and we all really love doing this, Feedback Fridays, where we'd go out and visit services. All of our senior leaders would do that and go and see frontline services on a Friday and then feedback at our trust business meetings. And that was very successful. Now, clearly, that stopped because of COVID. We've gone to a virtual format, big listen, big conversation. But, Charlie's now his teams are leading another piece of work to say, how do we get more back to that regular kind of contact, face-to-face contact with frontline teams? Because I think that does need to be more in the lifeblood of the trust than we've been able to do really during COVID.
Thanks, Elizabeth. That's a great answer. And you've clearly been developing this approach during a pandemic. So I wonder if we just touch on the impact of the pandemic. Has it accelerated the work you were doing, or has it created barriers? Who wants to kick us off on the impact that the pandemic's had on this work in particular?
Shall I
go?
Yeah. So I'm the executive lead for the pandemic response. I think it's both things, Miriam, if I'm absolutely honest. It has been interesting to watch the pace of change in the trust dramatically increase. And there is a bit, I never used to like the Cotter burning platform metaphor, but actually the pandemic did, there was, I think one of the phrases was a coalition of chaos, wasn't it? Because we were all so energized and so made, and all pulling in exactly the same direction, that change happened very, very fast. We did use some QI for some of the more complex things we had to, and any of those on the call here, if you work in a community trust, much of the guidance that came down from the centre was very acute centric, wasn't it? So a lot of the things that were coming down, even infection prevention, we were lucky that people mentioned that community trust existed. So there was a lot of adoption, adaptation, thinking, and then change processes to get that in. And we used QI to help some of that change. We also, though, were and still are in a major incident, and it was a command and control model. And so some of the reflections I've had as the executive lead for that incident was a lot of the time people just had to do what was mandated from the centre and use whatever change methodology suited best. But I suppose what it gave us was we did have a choice of change methodologies. People could adapt and think about what do they need to do and pick what sort of change support beneath them. Did they need project management support? Did they actually need to go and build relationships? Was it more relational? Was it more complex? And actually, sometimes I would say we flipped into chaos. And I would think, what can I do to bring that back into a manageable? What are the constraints I can put around it? And I actually use quite a lot of technological tools. I talk about the use of a Trello board, which is an agile project management board, to help contain some of the franticness in those first sort of few months of the pandemic. So the answer is yes and no, if I'm honest. I think doesn't really help you, Miriam, but I think that is probably an honest answer.
No, honest answers are what we're looking for. And go on, Charlie.
Sorry, could I just come in quickly on that one as well? I think the other thing it did on more practical level. So, I mean, I hated Teams to start with, I have to say. But I think one of the things I've learned is it got very quickly, it's allowed some of the improvement work to be trust-wide. So where we struggled with networks because people could be 25 miles apart and in different boroughs or indeed different counties, it's facilitated a sort of more cohesion across the trust. And the other thing I think it's done in the pandemic, it has, so I was really clear when we stood down things that shared governance could just continue with the support and people made their own choice. I mean, otherwise you're breaking the principles of shared governance. We said, if people want to continue with their work in the pandemic, continue. If you're too stressed or too busy, then stop. And actually most of our councils continued. And as Elizabeth said earlier and alluded to the joy at work, it really did help, I think, some people get through a particularly difficult time and also an isolating time. You know, we've got people that had to work at home or were working on their own more, and I think it really helped. So they were almost side effects of things, but they were, for me, were really important things that happened as well.
Thanks, Charlie. And Carol, I don't know if you've got a sort of non-exec perspective on the pandemic and how it impacted on this agenda in particular. Is there anything you'd want to add?
Yes, I think it probably, focused our minds more. I think it was Joanne who had a really great model, which is what are the services that we will ultimately want to restore and return to normal? What are the services we will want to retain? They're new, we've had to introduce them as a result of COVID. Do we want to retain them because, hey, they're good, we should stick with them? Mm-hmm. Where we had to reinvent things and do things differently, let's be clear about those. And where are the things we need to remove, we can stop doing. Actually, COVID has showed us we don't need to do them. So I think using that filter I find very helpful, because it has focused us on where can we add the most value in terms of we're embarking in this quality improvement journey, where can we get the best improvements in terms of things we have reinvented, things we want to retain or restore. So I found it very helpful in doing that with that kind of COVID lens. Does that make sense, Miriam?
Absolutely, it really does, yeah.
Restore, retain, reinvent and remove, I think has been very helpful for us.
Yeah, and I think that brings us on nicely to my next question for each of you, really, which is, how do you see quality improvement expertise helping you meet the current and future challenges that we're all going to be facing around recovery and transformation? Where to start? I'm going to come to Elizabeth first. You're cheeky.
Yeah, I mean, I think the critical thing for me is to continue with the work that we've been doing through the lens of joy at work and the links that we've got there around staff health and well-being. There's a coalition of staff really right across the trust, drawn from different teams who have developed a lot of skills in this area, and that is not going to go away. You know, our workforce is our most critical issue at the moment, simply the level of demand on them, the relentlessness of the work that they've had to do, the vacancies that we're grappling with. So anything that we can do for staff health and well-being, and really thinking about how do we work flexibly, how do we see things through the eyes of frontline staff and really listen to what they're saying. Those skills are absolutely invaluable that those teams bring, whether it's through shared governance or quality improvement. I think the other thing, and Charlie alluded to this, is the link that has made through technology right across the trust. So it's just the speed of change has grown rapidly, and it's being supported by that technology. So the learning that we can get and the spread is so much greater than we could ever have done pre-COVID. So I think that's absolutely critical. So whether it's to do with staff health and well-being, initiatives for restoring our services, looking at waiting times, addressing inequalities, all of these things, we can use the skills that we've got through the QI team, but actually it's the technology that's helping us share that learning as we're going through those PDSA cycles with different groups of staff in different parts of the trust.
Thank you. And Jo.
2 bits from me, Miriam, as I'm thinking about it. So there is actually it feels like as a community trust, we've gone from being commissioned to do quite a linear static service, health visiting, district nursing, etc., to saying, right, what can you do to help the system? And actually to help the system, we've done things like give IV furosemide in the community for people with heart failure. We're setting up a virtual hospital. These are all massive, massive change propositions. And not only are they change propositions for our staff, they're change propositions in the interface between the acute and the community in general practice. So there's a whole load of change around that. And all of these techniques help and support our change ambitions. And not just for the trust, but for the patient who's in the system, in the pathway. How can we make that better? And there are multiple ways using even things like the oxygen telemetry that we brought in under COVID, massive shifts in how that's done. The other bit, which is slightly more aspirational, and I want to pick up on the inequalities point. We are a London-based trust, and it is very striking, the inequalities across our population. We cover Kensington and Chelsea, and the starkness of the poorest compared to the wealthy is amazing. It shocks me every time I look at the data on it. And one of the things we are looking at is what is our role as an anchor institution? What is our role in trying to address population health, and how do you help empower citizens? And we are starting to talk about, in the new clinical strategy I'm writing, it's about how do we offer our QI expertise into the populations and the organisations that are non-statutory that are across us to help them make their own change in that wider determinants of health, which we can advocate and support and maybe give a bit of expertise, maybe a bit of financial support too. So I see us developing that agenda around our population inequality much more strongly over the next 5 years. And we've got some really strong clinical advocates for that who have been doing the Deep End project, for example, in Hammersmith and Fulham for the past 2 years. And we're going to build on some of that, which is all underpinned by QI.
It's fascinating bringing those two agendas together. That's really interesting. Charlie and then Carol, what about sort of next steps for you?
I think at the moment, you know what, I just want to progress the work that we've been doing. It's kept us agile. It'll keep us agile. I would imagine there's a few more pandemic related surprises, either by what the virus does or by the technology that's devised. So this, I think, will help us when we're solving those problems, or our staff, more importantly, are solving those problems. And also the other bit of keeping morale up. I think we just need to continue because it has really helped. And I think it's really important because people are weary. We all know people are weary. And, you know, this weekend, people are probably thinking, oh no, another set of rules. So I think it's really important that we use it in that way. It's not just a practical approach to change. It's something that makes our staff feel better in work and outside of work as well.
That's a great answer. Carol, how about yourself?
Yes, I think looking ahead, it's about staying true to the vision that we have as a trust and as a board about what we want to do around quality improvement, shared governance, our quality strategy. I'd like to think it's a bit like a stick of rock, you know, wherever you cut us and look in, you can see QI kind of the lettering imprinted in our DNA. And I think we have to hold on to that because it's easy to get distracted, but it's such a powerful movement for change for us. It would be difficult, I think, for us not to continue with that. And I'm mindful of a couple of questions in the chat there about how do we make it meaningful to people, whether it's a junior doctor or porter, whatever. And I think it's about being able to demonstrate, particularly through Charlie's quality councils and shared governance initiatives, that this has meaning for you. You know, you said, we did, even better, you said, and you did, because we helped you to put the changes in place that improve the quality. So I think it is important to do that. And as non-execs pre-COVID, we would make visits out and about, and you can have conversations with staff, whoever they are, to talk about their work and their experience, and to talk with patients and service users and feed in what quality improvement may have been able to do to help them see the benefits that they're experiencing. So I wanted to pick up on that. And there was a question about SPC, and I think Joe's said we've applied it in so many different things. But going forward, what we've done at the Quality Committee, with Charlie and Joanne, as we've mentioned, is to demonstrate the value of SPC. So we now look at trends, and we're about to apply those wherever we can across the board's KPIs as well. So I think going forward, the board will see the benefit of having that applied to some of its non-clinical KPIs, if that makes sense for you. So that's what I'm looking for. Maintain the momentum, the aspiration, and show the tangible benefits to both the board and to staff.
Fantastic answer. Thank you all so much. I'm mindful we are quite short of time today, but it would be good just to touch on how you describe how you've resourced your model. So there's a good question in the chat there as to whether your QI team is larger than in other trusts. Any comments on that? It's obviously integrated throughout everyone's job, isn't it? But any kind of comments on how you've gone about kind of resourcing your approach overall?
So it was just before the pandemic that the board agreed to increase resources for the QI team. So we've got a team of about 10 or 12 staff now across the trust. We are a very large dispersed trust covering 11 London boroughs and up into Hertfordshire. And I think that was one of the things that we were really struggling with before. We had a team of 3 before, so it's a significant level of investment. And that very first phase of the pandemic was when that team was recruited, and they are fantastic. But we have also got other, resources in other parts of the trust. As you say, there's a lot of kind of clinical support, knowledge and expertise around QI throughout the trust, with other people who haven't got those dedicated roles. And we've got a small shared governance team as well. So I'm not sure how that is compared to others. I think the thing that we haven't done is that investment in partnering with a large external organisation. So we haven't gone down the Virginia Mason route or whatever. And that's a different way of doing it, isn't it? This is essentially internal investment. But we have had those interventions. So we did a set of 3 board workshops. In fact, we just had the 4th for Making Data Count with NHS Improvement. So that was certainly a help for us as well.
Thanks, Elizabeth.
And Elizabeth, perhaps I could come in. So it's quite unusual to convince Trust to put the resource we've put in, I think, to shared governance. So I have an associate director, a really senior nurse. We have quality fellows and an 8A post as well. And we could probably have more. But one of the things we did is, so we've got an academy which looks really at education for inside the Trust, but we do external commissions. And with the income that we don't, the income doesn't go to the Trust bottom line, the income we reuse. So one of the things we do is when we do things like, we provide training for other organisations, the money comes back in, and Holly, who's the Deputy Chief Nurse who runs that, uses that money to invest in quality improvement or shared governance as well. So we do use it for short-term posts, and that also gives the benefit of giving experience to staff to come in and do things at a corporate level. So we have used that, I think it's fair to say, to our advantage.
Fantastic, thank you. And there's some really interesting questions coming in just as we're getting really close to time. So I'm just going to go with one of them and then I'll sum up really briefly at the end. So interested in the role you play within the system. Have you had any wider conversations with system partners, either about a consistent approach or about sharing your expertise a little bit more broadly? I'll come to Jo for that one briefly.
So I'm going to be very honest with you. It's quite interesting. QI in systems is quite a busy space. And I think one of the things that happens to us, and I'd be very interested in other people's reflections, is often the acute QI expertise is maybe a bit louder, a bit better at selling itself than us, mainly because, they're in one ICS. They're often, so we work with the Royal Free, Imperial, Chelsea and Westminster. They're very big teaching trusts with very big reputations. And then here we are, the community trust, pottering along doing our thing. So it's sometimes there's a power differential and there's a differential in the size of our voice. I think our response to that is we have just carried on. We've just carried on. We've been tenacious with it. We do talk to, we are very open, very keen to collaborate. But often the sense is that there isn't the willingness to actually hear us in that space currently. Now, this is because we've just come out of a highly competitive world where often we were being threatened to be decommissioned, but we're going to be decommissioned. So we are in a very different transitional space, and I'm really optimistic that maybe a community voice becomes equal to a teaching hospital's voice. But currently, that is not my experience.
Elizabeth, did you have
if anyone wants to talk to me about that, yes, of course you can drop me a line.
If I can just build on that though, Jo, it's interesting, isn't it? So the NHS England guidance for provider collaboratives said that there was an expectation that collaboratives would have a shared approach to quality improvement. So for us in North West London, the 4 trusts that are providing community services, those 4 QI teams have come together, and we are developing a shared approach to QI across the community providers. So I think that's happening already, but it's interesting that it's in the community space.
Thank you. It is indeed, isn't it? Well, I'm mindful of time. We could talk for so much longer, and thank you so much for such a rich and very frank and open conversation, and for being willing to share your journey with us. Colleagues, if you've got further questions you wanted to ask, and for those that we've not managed to cover, we'll wrap those up and we'll try and get answers to you online as part of the wrap up to the event. So if there's anything more you'd like to ask, do either drop us a line at NHP or any of our panel members, and we'll try and answer those remaining questions in the wrap up to the event. So I'm really struck by the board level support you've built for the agenda, the clinical leadership and clinical advocacy that you talked about, and the emphasis that you've all put on staff engagement, staff well-being in particular. And I think those kind of comments about the role in the system and bringing together a QI approach with the means to tackle inequality inequalities, really fascinating as well. So thank you so much to our panel. Colleagues, please do fill out our evaluation form when it comes your way. We do take your feedback very, very seriously, and we will be back in touch with the next series of events in this programme, and also with our board bites, which is a handy digest of everything that we've learned thus far. So thank you again to our panel and to all of you for making the time to join us today.